Hello. Today we're going to discuss drug interactions in acutely sick patients, and this is an often neglected topic. So here are my declarations, and I want to start by giving you a couple of case histories to illustrate just how complex and difficult these patients are to manage sometimes. And from these, we can tease out underlying principles that underpin how we can manage acutely sick patients and drug interactions. And I'm going to give you some examples of common pitfalls. So let's start with the case histories. So the first case is a 36-year-old man who was diagnosed HIV positive in 2018, and he presented with very late disease, so CD4 count of only 14 cells, a viral load in excess of 10 million copies per mil. He presented with a history of several months of severe weight loss and a low-grade fever, and on clinical examination was found to have hepatosplenomegaly, and investigations revealed that there was also evidence of intra-abdominal lymphadenopathy and pancytopenia. So you can see from these CT scans here that the liver is enlarged. The spleen is very significantly enlarged, in some cuts lower down, almost the same size as the liver. And here's the aorta, and if you follow the aorta as it tracks lower down, you can see that there is enlargement of the para-aortic lymph glands and some mesenteric lymph glands as well. He was found to have oral thrush and perianal HSV, which was all in keeping with his late stage presentation. Blood cultures were negative, as was his cryptococcal antigen. He underwent an endoscopy and esophageal candidiasis was confirmed, but also on duodenal biopsy, Mycobacterium avium was seen and subsequently cultured, and this was confirmed in cultures from his blood and his lymph node aspirate. So this confirmed the diagnosis of disseminated Mycobacterium avium. So we started him on Mycobacterium treatment, which was rifabutin, clarithromycin, and ethambutol, and at the same time also started him on abacavir, 3-TC, and dolutegravir in view of his very high viral load, his very late stage disease. That's a situation where antiretroviral therapy needs to be started pretty quickly. He was seen again about 6 weeks later with a blunted viral load response, so it hadn't really shifted from its baseline level. And there was concern about the potency of the regimen. So darunavir cobicistat was added. His treatment was intensified to Triamec and Resolstra. Round about this time, he was noticed to have persistent pancytopenia, which hadn't really budged on MAI treatment. And he was transfusion dependent and had persistent fevers. And because of that, we were concerned that we might be missing an underlying lymphoma, which is part of his rather complex presentation. So an FGG PET CT scan was arranged. And this showed a metabolically hyperactive spleen. So you can see the spleen lighting up here in the axial sections and coronal sections. And also the lymph glands, the para-aortic lymph glands and the mesenteric lymph glands that we talked about were also lighting up. And as part of this lymphoma workup, we proceeded to do a bone marrow aspirate and trephine. And the results came back somewhat surprising. So there was no evidence of lymphoma, but instead, in some of the bone marrow aspirates, we were able to see these little purple bodies, these so-called LD bodies that are intracellular amastigates of leishmania. So he had visceral leishmania, which rather explains the massive hepatosplenomegaly, the persistent fever, and the pancytopenia. And as a result of that, he received his Triamec and Resolstra and also started on liposomal amphotericin B together with his rifabutin, clarithromycin, ethambutol, and other medications. He was seen again approximately 6 weeks later with a new lesion on his nose. And at the time, a serum HHV8 PCR was done, and that showed a rather high viral load for HHV8, and a skin biopsy confirmed Kaposi sarcoma. He was therefore started on chemotherapy. So now you can see this considerable list of medications, all apart from escitalopram, was started within the preceding 12 weeks. Thereafter, fortunately, he stabilized and he remained well and was discharged home. However, he still remained pancytopenic. So this is his hemoglobin, his white cell count, and his platelets, and the green shaded area represents the normal range. And you can see that he remained persistently anemic, requiring multiple transfusions, persistently leukopenic and thrombocytopenic as well. He presented again nearly 9 months later, admitted from clinic with a sudden deterioration in his renal function. So his kidney function had previously been running with an eGFR of over 60 to 80. And in a space of a few weeks, it had dropped very suddenly to around 10 to 15. So this was a very significant drop in his renal function. Ultrasound scan was normal. There was no evidence of obstruction. And we were worried at that point as to whether this might be a drug-induced acute kidney injury. But the amphotericin had been started many months ago, and he tolerated that pretty well. And so we were concerned that we might be missing some other underlying pathology. So with that in mind, we undertook a renal biopsy, and that showed tubulointerstitial nephritis. And on staining, there was evidence of some acid-fast bacilli, which were not cultured. So this would be in keeping with a picture of a very advanced presentation, disseminated mycobacteriosis, and then an iris with an immune nephritis. And after some considerable debate, we did the following. So we stopped his antiretrovirals as he came in with acute renal impairment to try and see what role they had and to try and make sure that we didn't make things worse. And his antiretrovirals were then subsequently modified, and we added in steroids. So here we go. He was given dolutegravir once a day, 3 TC, a renally adapted dose, and added rilpivirine. So this was a sort of a little bit of so this was the regimen that was determined to be optimal for him at the time. He continued on his MAI treatment, but the ethambutol was stopped in view of the renal impairment. And we added methylprednisolone at a dose of 1 gram daily for 3 days. He was seen by multiple teams at the time, including the kidney team and the dietitians, and they had started calcium and sodium bicarbonate for his acidosis. And this was not picked up at the time by our team, because clearly there are concerns with drug interactions between the calcium and the dolutegravir, and between the bicarbonate and the rilpivirine. And over the next few months, his viral load continued to decline, although he remained persistently detectable over the course of the first year of treatment. A resistance test was repeated a year after starting treatment. And this is his baseline test, which showed a fully sensitive virus. But a year later, in the presence of detectable viremia, he had developed an M184V mutation. It's unclear where this came from. There are a number of explanations. For example, he had persistent viremia in the presence of drugs. But also he had a treatment interruption when he came with the acute renal failure. And most worryingly, of course, he had received the bicarbonate and the calcium. So if the rilpivirine and the dolutegravir were compromised, that would have explained very nicely why he had developed the M184V mutation. So with that in mind, his treatment was again switched to twice daily dolutegravir, to maraviroc, and to boosted darunavir. He was continued on his KS treatment and more recently switched to Biktarvy. So I'm going to move on to the second case now. The second case is an African female, 37-year-old, diagnosed as HIV positive in 2008 in Zimbabwe. Nadir CD4 count was 40 cells, and baseline resistance testing indicated wild-type virus. She was started on a tripler, and over the next 10 years, unfortunately developed a psychotic illness, developed progressive weight gain. So her weight which was high to start with, increased to 132 kilograms with a BMI of 48. And rather unsurprisingly, she was also diagnosed with type 2 diabetes. She was a poor clinic attender and a poor adherer, and had subsequent virological failures. And this chart here shows her progress. So virological suppression initially, but with intermittent blips throughout the time. CD4 count was reasonably stable in this time. She was started on a tripler. She moved on to Truvada plus boosted darunavir, which was simplified to Simtuza. She was still poorly adherent and did not like the size of the tablets, and was moved to Truvada and dolutegravir. In December 2019, she represented with an acute confusional state, with headaches, with fevers, and with a degree of neck stiffness. She had missed her antivirals at this point. Her CD4 count was still stable at around 400 cells. Her viral load was detectable around 250 copies. And initially, she was managed with ceftriaxone and acyclovir for presumed bacterial meningitis and herpes encephalopathy. A lumbar puncture was undertaken, and that revealed a lymphocytic CSF, so elevated white cells, 100% lymphocytes, protein was up, and glucose was low. Her MRI scan is shown here, so there was a widespread subcortical white matter abnormality. You can see some in the frontal lobes just here, and so evidence of some mild leptomeningeal thickening. So this entire clinical presentation to us was strongly suggestive of TB meningitis, together with her African background. At the time, she was found to have a mild kidney injury, complaining of vivid dreams and inability to sleep. Acyclovir was stopped, and we started anti-tuberculous treatment with rifampicin, isoniazid, pyrazinamide, and ethambutol. And in keeping with the guidelines as a result of the Vietnam data, we started high-dose dexamethasone, so 16 milligrams twice a day. Zopiclone was also started, and we did a resistance test on her because she had evidence of high-level, evidence of virological escape, and more importantly, in her CSF, there was high-level virological escape in the CNS with a CSF viral load of over 1 million. Unsurprising, given the degree of inflammation in her CNS. And that showed widespread resistance to NRTI. So there was an M184V, an L74V, K70Q, and also K103N, so NNRTI mutations as well. Her antiretrovirals were switched at this point. So here is the chronicles of her antiviral therapy. So here she was on a tripler, onto Truvada darunavir, onto Simtuza, and then Truvada plus dolutegravir, during which time she developed TB meningitis. We doubled the dose of her dolutegravir to twice a day, but she was found to have persistent CSF viral escape, and therefore was switched to zidovudine, not a drug we use commonly nowadays, lamivudine, double dose maraviroc, and double dose, well, in fact, dolutegravir was doubled, and then it was doubled again. So it was 100 milligrams BID of dolutegravir. A few months later, after starting this, she became confused and psychotic, and we were not clear whether this was part of her continuing background of psychosis, whether this was due to CNS disease from a TB meningitis, or whether this was drug-related. But so it was decided to switch her dolutegravir at that point to double-dose raltegravir. So over here on the right-hand side, you can see the list of her drugs and the potential interaction with rifampicin, the dexamethasone, which was 16 milligrams a day, I beg your pardon, and metformin. She remained well, although in hospital, requiring neurological rehab. And of course, rehabilitation is quite slow in these patients. And in April of this year, 3 months into TB therapy, so in continuation phase, she developed sudden onset of fever, and you can see her temperature shooting outside the normal range at this point. Breathlessness and hypoxia. She required 30% oxygen in this period, and an abnormal chest X-ray. Her CRP had shot up at this time, and her liver function became rapidly abnormal as well. D-dimers were done, and as we were in the middle of a COVID pandemic, and this was very markedly elevated. The new score here is an indication of how acutely unwell she is. So it's a combined, a composite physiological score of oxygen saturation, respiratory rate, heart rate, blood pressure, oxygen requirements, temperature. And you can see anything over 5 triggers an urgent medical review. And you can see she was medically very unstable in this period. Her chest X-ray was also abnormal. So this is a PA film showing some cardiomegaly and some diffuse shadowing in her lower and mid zones, which was progressive. And a CT scan here shows, first of all, her extreme obesity, a very large heart, and ground glass shadowing in both her lung fields, which was widespread throughout her lungs, organizing in some places. So this was a picture that was thought to be very characteristic of COVID-19. And her swab subsequently came back positive, confirming the diagnosis. She clearly has risk factors. Her obesity, her type 2 diabetes, and her severe hypoxia was a marker of the severity of illness. She was reviewed and deemed not to be a candidate for the intensive care in view of her comorbidities. I might say in May, we were into the middle, we were in the thick of UK national pandemic, and the intensive care beds were completely packed at this point. We determined that the ward-based continual positive airways pressure was the ceiling of care for this lady. By then, we had started to use remdesivir and were starting to use dexamethasone. So she was started on remdesivir and dexamethasone together with antibiotics, this is our policy, and anticoagulants, which again is our policy for all these patients. The problem here is that she remained on rifampicin at this point, and there are significant interactions between rifampicin, remdesivir, and dexamethasone. So we took the view that we would stop the rifampicin. Her need for COVID treatment was clearly pretty urgent, and the offset of rifampicin would take several days for the induction to wind down, but we went ahead and started remdesivir anyway. There was no possibility of dose modifying the remdesivir. We gave her dexamethasone, and we were giving her a double dose in view of the background of rifampicin. So for those of you who are interested, we have a drug interactions website, covid19-druginteractions.org. And this gives you the potential drug interactions with experimental. So these are all unproven, except for remdesivir and dexamethasone, unproven experimental therapies for COVID-19. And this is to help physicians weigh up the benefits and the risks of giving these treatments. And you can see here that for strong inducers of cytochrome P450, such as rifampicin, such as carbamazepine and phenytoin, co-administration with remdesivir is contraindicated, and that's because remdesivir levels will fall. For moderate inducers of P450, so this would be rifabutin, oxcarbazine, and basantin, remdesivir can be dosed normally, and remdesivir is a drug with high hepatic extraction, is less likely to be impacted by moderate inducers, although very likely to be impacted by potent inducers. For dexamethasone, any inducer, moderate or strong, the dexamethasone dose should be doubled, and this is clearly only for a short period of time. And the dexamethasone doses that we use, 6 milligrams a day, are quite low, so clearly could not tolerate much more lowering by a potent inducer. So what are the lessons that we can learn from these patients? So first of all, drug interactions are more likely to pass unrecognized when patients are very sick. And this is partly because there are so many teams involved. And each of these teams, the intensive care team, the respiratory, the cardiologist, the renal, the infectious diseases teams, are less familiar with drugs used by other people and other teams. Recording of medications needs to be very carefully done and elicited, particularly with things that are not orally dosed, so topical treatments, injections. Viral load is not repeated during acute illness, and that's absolutely correct. But that also means that that drugs that impact adversely upon antiretroviral therapy may not be detected. Okay? QT effects are often summative, so you're giving them multiple drugs, 2, 3, 4 drugs, all with some QT effects, and these are not often considered. And even when drug interactions are recognized, they may be considered relatively unimportant amidst the melee where someone is going to get intubated, going off to theater, getting anesthetics. Drug interactions very often don't feature as top of the list. The other issue here is that drug interactions are also more likely to cause harm. So if you get a drug interaction, you may have no harm and get away with it, or you may suffer harm. In a sick patient with multi-organ failure, and very often there is renal impairment in these patients, drug interactions may have greater propensity to actually cause harm. And not only that, but when the harm develops, they are misattributed to the disease. So you've got an arrhythmia and you say, well, that's COVID myocarditis, rather than a QT prolongation with hydroxychloroquine, for example. Drug interactions may also be harder to manage. So very often we try and avoid use of narrow therapeutic index drugs when there are alternatives, but there may be no alternatives in acutely sick patients, particularly with arrhythmias where you might need amiodarone or some other antiarrhythmic, for example. Patients may have swallowing difficulties, very often they may be unconscious, they may be intubated and ventilated. So we have on a Liverpool website a resource which you can pull down from treatment selectors, which tells you how you can administer drugs to unconscious patients, which pills are available as syrups, which ones are crushable, dissolvable. And a common question we get is dolutegravir, because there's concern with all the ingredients of nasogastric feeds. Can dolutegravir be crushed and mixed with NG feeds? And the answer is yes. There is good clinical data from one study showing that the absorption of dolutegravir, in fact, is slightly increased when administered with NG feeds. Don't forget that in an acutely sick patient, you've got to treat whatever is acutely sick. So whether it's an acute surgery or organ failure that's required, or whether there's a cancer that needs urgently treated, and stopping antiretrovirals if you can't manage a difficult situation is always an option. Perhaps not always, because we're in the era of intramuscular cabotegravir and rilpivirine now. And so you can't get these drugs out of the system. So that may not necessarily be such an issue, but if you have an issue around QT prolongation, for example, if you have an issue around adding rifampicin or a potent inducer, or if you have a new onset of liver failure, then actually exposure of these drugs may be very variable, and that needs to be anticipated, and you may need to think about how you cover the tail of these drugs in order to prevent resistance emerging. And lastly, I'll finish with the common pitfalls that I've experienced, both in our practice and just observing all the day-to-day care of sick patients on our wards. We're very used to rifampicin creating an alert for drug interactions when someone's on TB therapy. But when rifampicin is given for staphylococcal infections, for example, people very often forget that it's also causing induction of steroids, of all the other drugs that are problematic. So anti-diabetic medications, cardiac medications. Very often treatments that are not really contributory in any way during an acutely severe and fulminant illness are not stopped. So I often see people who are very sick, unstable blood pressure, still receiving a statin, still receiving antihistamines and other drugs. And really, it's important to stop all these drugs and just clear the water in such situations. Drug interactions come in all sorts of manner and from all sorts of directions. Very often, people with renal failure will see a renal dietitian who will prescribe nutritional supplements, and this will pass unnoticed by the medical team, and clearly that could impact on integrase inhibitors. Also, PPI use is widespread in these patients, sometimes as treatment, sometimes as prevention. And again, this will impact with patients on rilpivirine and atazanavir. We found the use of DOACs to be widespread and increasing all the time. Apixaban, rivaroxaban, and in a patient who's unstable, these drugs, which have a narrow therapeutic index, can be difficult to control sometimes. And very often, our team will preemptively switch patients from these DOACs towards fractionated heparins, which are much safer, much more controllable. In this scenario, with a short half-life, you can actually titrate it. And of course, it's important for all prescribers to recognize narrow therapeutic index drugs. And in the case of acutely sick patients, these include anticoagulants, antiarrhythmics, antiepileptics. So I'll stop at this point, and I do want to thank all my colleagues, particularly those people who worked hard night and day to get our drug interaction service up and running. Thank you very much for listening. Look forward to your questions.